Good morning, everyone. We've still got a bunch of people trying to get admitted into our meeting today, and so we'll give it just a few more minutes to let the lobby calm down a little bit. Do we have our Milliman partners online with us?
Hey, Jason, Andrew's here.
Okay, perfect, Andrew. Thank you.
And Jason, I just saw Maria's on as well. So we're good.
Excellent. Thank you, Andrew. Hey, I did.
See for what now?
All right. It sounds like our lobby is slowing down a little bit. Those that come a little bit late, we'll continue to let them in. But good morning. Welcome to our public workshop provided by Nevada Health Authority. My name is Jason Blake. I am the agency manager that has responsibility over the Rural Health Transformation Program, and it's a pleasure to be with you. I can't think of many better ways to start the morning than to have a public workshop, but we have a very important subject to go over today, another one of our funding initiatives for our program, and I look forward to hearing the information and then trying to answer some questions. So we'll first start, because this is a public meeting, I'll open with public comment. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and spell their last name, and provide rhtp@nvha.nv.gov with written comments. Comments must be provided up to and including the day of the meeting by 5 p.m. for inclusion on the record. Do we have any public comment to come forward at this time? If so, please unmute yourself or raise your hand. Is there any public comment? Hearing none, we will move on to our main event of the agenda, and that's our presentation regarding the Rural Health Outcome Accelerator Program. I'll spend just a couple of minutes to begin the program, or to begin this presentation. But before I go any further, I should introduce our friends from Milliman, Marie Zimmerman and Andrew Badaracco. These two have been instrumental in helping us write this request for application, and also helping us manage through this workshop and all the processes involved. And so you'll get to hear from them in just a few minutes, but I want to recognize them and welcome them to our workshop. So for our workshop, and whoever is working the slide presentation, if you could move forward to our agenda. This is the agenda that we will follow. First, we'll have I'm getting a lot of feedback from somebody. First, we'll approach the Rural Health Transformation Program overview, which I'll take care of. Following that, we'll have the RHOAP or RHOAP funding opportunity and eligibility. We'll then talk to application requirements, then scoring criteria, and then post-award requirements, and we'll wrap up at the end with submission summary. So this information is not new. The Rural Health Transformation Program has been out for a little while, and we've been working feverishly to get everything moving along very quickly. I must take a second to thank the team here at Nevada Health Authority that is working so diligently to move this program along, from our head, Melinda Southard, all the way through each employee that's working on this. Marvelous efforts have been put forward, and we have seen great results to this point. So the overview of our program is that the RHT program is a federal program put out across the United States with a focus to improve healthcare access, quality, and outcomes by transforming healthcare delivery ecosystems. The state programs are tasked with focusing on rural and frontier communities. And if you have been part of this process from the beginning, you'll find that that is a focus. And we are ensuring that these monies and these benefits are going to the rural and frontier communities of our state. CMS awarded Nevada in a 5-year Rural Transformation Cooperative Agreement nearly $180 million. And that's a 5-year program, and we expect to receive around that amount each year for the 5 years. That could vary depending on different metrics that are accomplished and managed throughout the budget periods. The final bullet point here is that NVHA is using separate funding opportunities, or RFAs, to disperse funds to support efforts to improve health outcomes, workforce supply, infrastructure, and technology improvements across rural Nevada. And to be specific, we have 10 RFAs that are in process at this time. So here in Nevada, we have 4 major initiatives that we are working on. First is the Workforce Recruitment and Rural Access Program, the RHOAP, and that is focused just on, as it's explained, our recruitment and rural access, our pipeline of employees into our rural areas for healthcare services. Second, and what we'll be discussing today, is the Rural Health Outcome Accelerator Program, or the RHOAP, RHOAP. This contains information about value-based and innovative care models to prevent and manage chronic diseases. The third piece is the Rural Health System Flex Fund. This initiative focuses on technology, equipment, supplies, mobile units, emergency services, and other infrastructure. And finally, our last initiative is the Rural Health Innovation and Technology. This focuses on digital health data modernization, cybersecurity, and telehealth infrastructure. So that's just a very basic overview of our Rural Health Transformation Program, not only over the space of the United States, but here specifically in Nevada. I'll now turn the time over to our friends from Milliman, Marie Zimmerman and Andrew Badaracco, to lead us through the next slides.
Great. Thanks, Jason. Appreciate it. I am going to start off, as Jason said, I'm Marie Zimmerman. I'm with Milliman, here supporting NVHA in these RFAs and RHT and all of the related things. We're going to talk a little bit this morning about, as Jason said, the Rural Health Outcomes Accelerator Program, or RHOAP. I will probably just say RHOAP because it's just easier and quicker to say for the remaining presentation, but we'll try to reinforce the meaning behind that throughout. So really, RHOAP is designed to strengthen regional health outcomes through strategic outcome-focused investments that encourage innovative and evidence-based models of care. You'll see there that the funding is just shy of 27 million for year one. And really the funding is intended to close what the state identified in its application to CMS as persistent gaps in care and rural health outcomes, especially for underserved and high need populations in rural communities. The state in its application to CMS outlined some key priorities for these gaps, and we're going to keep coming back. You'll hear these kind of over and over again throughout the presentation, which are interventions and management related to chronic disease, primary care, behavioral health, and maternal and infant health. So those are the key priorities of the RHOAP initiative. What the RHOAP RFA really emphasizes is measurable impact, sustainability, and cross-sector collaboration. So this is really meant to be a targeted investment to build ongoing system capacity for this work. Next slide. So for those of you that may have paid attention to the first couple of RFAs, the two RHAP RFAs that were out using this tiered funding approach, the RHOAP RFA uses a similar tiered funding approach, so the funding can align with the applicant readiness, scope, and also the expected impact. This approach is intended to provide guidance to applicants and ensure that there are a range of opportunities, both in terms of size and scope. I just want to be clear that these tiers are estimates, both in terms of the funding level and the number of awards. The actual awards will be based, of course, on the applications, and the final awards at the discretion of MVHA and through the evaluation committee as well. So tiers 1 and 2 are really kind of aimed at supporting the planning, the infrastructure prep, sort of those foundational partnerships, as well as implementation and expansion of interventions and programming that may already be in place, for example, or might be new and starting up. Tiers 3 and 4 represent programming that might be more mature and ready to scale, or might have more of a regional influence or impact intended to address, for example, more than one RHOAP priority or more than one RHOAP program category, which we'll talk about in a little bit as well. This approach is really meant to ensure that there's equity in the application process by allowing organizations that are at different maturity levels to participate in the application and also grow as the program continues. So just some examples for folks in the different tiers. I'll just give an example for tier 1. That could be a rural health clinic receiving planning funds to complete a community needs assessment, build referral relationships, and stand up a reporting dashboard. A tier 3 example could be something like a multi-county collaborative that expands a maternal health model and having some shared analytics quality targets and some cross-organization governance, for example. So again, these are just examples and meant to be guidance for applicants to follow. Next slide. So of course, what comes with any sort of federal funding, there's always rules on what the spending can be used for, and the funds are designed to support. So of course, these funds could support care delivery, redesign, things like technology enablement, staffing, training, data, reporting infrastructure. All of those categories are listed there on the far left of your very standard personnel, travel, training, operating costs. All of those things are in the details of the RFA, for example. All of the allowable expenditures will include activities that will directly improve access, quality, care coordination, and of course, improving health outcomes as well. The spending, and Andrew will talk about this a little bit later, really needs to demonstrate a clear linkage between the approved goals, timelines, and performance metrics that folks put in their application. I will just say, maybe as a overall, and I'm sure folks have been doing this already, they should take the opportunity to review the MVHA website. There's good information out there around the allowable expenditures, as well as the CMS fact sheets to better understand the funding rules. As always, there are restrictions on some of those things, including not ensuring that we're not displacing funding that's already reimbursable through health insurance, for example. And here we just provide an example of something that would be an allowable expense, which is hiring something like a community health worker, community health representative, a peer support specialist, et cetera, as part of an early workforce integration initiative that is part of building an integrated care team. Andrew, anything important that I missed on that slide before we move on to the next slide?
No, I don't think so.
Okay, great. All right, so in the next few slides, we're really going to talk about section 3, which is the eligible applicant section of the RFA. This section is organized into, it's a little bit different than the RHOAP RFAs in that it's organized into the types of programming from the state's application intended, again, to impact those key priorities of chronic disease, primary care, behavioral health, and maternal and infant health. So programs that are submitted must focus on at least one of those priorities, but of course, applicants can include programs for more than one priority, and they can also apply for more than one program category as well in the RHOAP RFA. So this first program category is the digital and hybrid care access, which is really aimed at reducing barriers related to geography, transportation, and provider access, for example. Priority activities could include telehealth workflow integration, remote monitoring, and digital navigation supports, for example. Hybrid models could include virtual and in-person care, clinically appropriate, and of course, patient-centered as well. Success could be measured by, for example, improved utilization, continuity of care, or avoidable emergency department visits. So a couple of examples here could be a health center introduces a evening virtual visits for working adults and then in-person weekend follow-up for lab and exams, or a congestive heart failure program uses remote monitoring with paired with nurse outreach, for example. There are some similarities across the program categories in terms of the types of organizations that are eligible to apply. So for the digital and hybrid care access, and I'll sort of note some of the nuances between them, includes rural providers, and there are some examples of that in the RFA, associations or networks of rural providers, state and local agencies providing services to rural counties and residents, and organized partnerships. So for example, if a provider wants to partner with a Medicaid MCO, and those type of partnerships require a letter of commitment or like a memorandum of understanding from rural providers to demonstrate that connection and that governance. And then for this program in particular is those companies that provide, for example, the technology that enables the digital and hybrid access to care, as long as they can provide a intent to contract, a letter of agreement, or a fully signed contract with one of the other eligible applicants. Slide. The community-based population workforce, population health and workforce integration is really about those strategies that address social and clinical drivers of health together. So programs could connect providers, community-based organization, public health partners through shared workflows. Workforce integration could include care coordinators, again, community health workers, peer support specialists, and multidisciplinary teams, for examples. Activities such as training and role clarity and referral loop closure would be expected to make any integrated care model operational, for example. Results could include things like better engagement, improved prevention and chronic disease outcomes, and stronger local care systems. So again, just some examples of a type of funding application that could be submitted would be a care coordination model that focuses specifically on the management of chronic conditions, or a regional maternal and infant health program that improves prenatal and postpartum access. Eligible applicants for this program category, again, similar to the digital and hybrid care access, with the exception of technology companies. So we're talking about the rural providers, the state and local agencies, and the organizations or the networks of providers or provider associations. And that's really because this is focused on building the integrated care teams and the workforce to support the evidence-based programs, but folks can still include those costs for vendors and other contracted support they need to operationalize those teams, for example. And the third program category is financial incentives for improved health outcomes, which is really focused on readiness and operationalizing for paying for improved health outcomes for rural residents. So this program really focuses on all of the readiness and operations needed to prepare for outcome-based payment, but also the payment itself, meaning the financial incentive that is paid directly to a provider. So some examples could include just the costs with establishing a network of rural providers and operationalizing data sharing and workflow between those providers in that network. And an example of a financial incentive would be, for example, a quality bonus payment for increasing prenatal and postpartum visits. Again, eligible applicants are similar to the other program categories, a little nuance here. Again, we have rural providers, we have networks of rural providers. In this one, we have payer-provider partnerships. So think about a Medicaid MCO or a Medicare Advantage plan. You know, those are the kind of payer partners that we're talking about. We provide some other examples. There are certainly others I'm sure that folks can think of, but that's really who's involved in a financial arrangement, is usually a payer and provider to sort of execute some of those quality and outcome-based payments. And the last one would also be vendors that will support these efforts are also eligible to apply, again, with that intent to contract, letter of agreement, or contract with one of the other eligible applicants as well. One last thing I'll say about this one is the state anticipates that much of the year one and budget period one funding for this would likely be more readiness and operational type activities. However, if there is a program that is ready for a direct financial incentive for year one, it must be through a payer-provider partnership. And lastly, as the state is thinking about what will be the priorities, what is it looking for in the applications, I'll just highlight a few things. One is ensuring that there is collaboration across the continuum of care. So healthcare providers, local public health, tribes, for example, social service agencies, really wanting to see that collaboration across. Of course, providing increased access and participation in the Medicaid program and also improving health outcomes for that population is a high priority of the state as well. Those that really can demonstrate and show those strong evidence-based and community-led strategies that address, again, the key RHOAP priorities of chronic disease, primary care, behavioral health, and maternal and infant health. Those that really can demonstrate the capacity for building a roadmap for readiness to participate with the payer or in an outcome-based payment. And another one that, for emphasizing in terms of priority is collaborative and regional uses of technology. I think one thing that's a challenge is if everyone goes and kind of gets their own technology, it's one of those things that's harder to sustain, which is also part of the program application. So really thinking about how that infrastructure can be shared amongst partners. And the last thing is really demonstrating, again, a strong sustainability plan and those continued partnerships and governance with rural providers. And I think that's it for me for the moment, unless Andrew has anything to add to that, and I will hand it off to Andrew for the next session.
Thanks, Marie. So now we're going to talk a little bit about what you need to do to apply. What are some of the administrative steps associated with applying, and just kind of giving some background on the overall application. If you've looked at any of the other RFPs that are out on the NVHA RHT website, you may be familiar with some of these components, but I will note that for the RHOAP application in particular, there are some additional pieces to keep in mind as we move through them. So as we go ahead, I'll make sure to call those out specific to the RHOAP. So first, this slide here, just want to highlight each application has these 5 primary components to them. They're the cover sheet, the budget narrative, the budget plan, the project narrative plus work plan template, and then finally letters of commitment. As Marie noted in her eligible applicant section, one thing to point out is letters of commitment are largely optional under this funding opportunity. There is one category of eligible applicant within those tiers that if you are submitting and you have partners that you're submitting an application with, letters of application in those instances are required. And so it's very important that when you're going through and verifying, which tier and which category you'll be applying under, and selecting whether or not your category of application requires level of commitment. So that's the one big piece I think that's different for this particular RFA versus some of the other ones that we've gone over before. And so if there are questions about that or any kind of any sort of confusion about that, make sure to send, you can raise questions here at the end of this discussion, or you can email the state in the RHT mailbox. But prior to submitting, it's important that each applicant goes through a few different particular steps to make sure that they're ready to meet the application requirements. First and foremost, applicants must be registered as a state of Nevada vendor to receive funds. You can apply at any point, but we would encourage potential applicants to apply as soon as they can so that step is out of the way. Applicants should use headings and subheadings and respond to each narrative question individually. There are a minimum of 3 SMART goals with at least 2 objectives each in the work plan template. And then finally, it should be pointed out that any incomplete, ineligible, or non-responsive applications may be disqualified before scoring. So it's very important that each applicant submit a full, complete application with all the components completed. Next slide, please. So first, the cover sheet document. So the cover sheet document is really just to gather information about who's applying for which opportunity they're applying for, and just making sure that the state has an ability to track and organize themselves around the numerous applicants that are submitting in response to some of these RFAs. As part of the cover sheet requirements, applicants should include the cover sheet template provided, complete all the fields, be sure to specify the funding opportunity you're applying for, and note that the budget period 1 is the application period that you're applying for, and that application period and the budget period runs from approximately August 2026 when the funds will be awarded through August 30th, 2027. And the attachment just includes a few basic pieces of information. Again, applicant overview, who are you and which are you applying for, contact information, total funding amount requested, the targeted service area that you intend to focus on within the state, any other federal funding you receive, as well as a signature from each applicant. Next slide, please. In the budget narrative, so this is a very important piece of information. I'll spend a few minutes just speaking about the component here. And so first, just generally speaking, when you're submitting your budget narrative, you should include all costs related to carrying out the particular funding objective that you are meeting through your initiative spending. So your budget narrative should explain how each requested cost supports the project scope and objectives and outcomes. And so focusing on whichever category you're applying for, making sure that those costs are specific to that category and well defined in the document. And these costs can include personnel, travel, consultant or contractor or subrecipient, and then other costs as well. And so each applicant should define and include, any cost that you anticipate spending using this funding should be estimated in your budget narrative document and explained along with the justification for those costs. A template has been provided for you to follow. And so as you're going through that, make sure you're using that template so that you're following, along with how the state would expect this information to come in, because it makes it much easier to review and score once that information comes in that uniform template. It should be pointed out, and we cannot stress this enough, the CMS funding of these, I apologize for my dog, the CMS funding of these opportunities is being done on a year-by-year basis. So the state has just received funding for their first year of operations, and they will get subsequent notices of awards for years 2 through 5. The funding under these RFAs align with that outline of timing. And so this funding is specific to year 1 of the budget year 1 of this program, and subsequent years funding is contingent upon CMS funding and discretion of NVHA. Applicants certainly in their narrative can talk about plans for, subsequent years, but the primary focus and impetus behind this budget narrative will be budget year 1. Next slide, please. And then budget plan. So this is just simply a itemized document which captures the accounting of those costs and just adding up to make sure your budgets are aligned. Again, for the budget plan, just things to consider. Indirect costs are not allowed. Administrative costs are allowed, but are capped at 10% of the entire request and must be explicitly identified. No cost sharing or match is required. For phase projects, as I just mentioned, applicants must clearly separate budget period 1 activities, goals, outcomes, and expenditures from later phases. Again, going back to how CMS awarded these dollars to the state. Subawards are reimbursed monthly, and budget changes require advance approval from the state. And there's more information we have about how you spend these funds, with particular focus on if you're going to spend this money on provider salaries, or bolstering staff. There may be additional 5-year service requirements, which we'll go through on the next slide. But all of this information is, you have a template with some examples in attachment C of the RFA, which you can follow along. There's some example justifications, there's some example numbers, just so you can see how the state expects this information to be submitted. Next slide, please. So for the project narrative document, this is really just where the bulk of the scoring of this application is really gonna live in your application. So first and foremost, the state would expect to receive a needs assessment document outlining the need associated with the funding that you're requesting and how you plan to meet that need. A work plan and impact analysis that shows once this funding as this funding is being spent, what are the expectations of the applicant in terms of how the funding will be used, what's the expected impact, et cetera, et cetera. There's some data collection and evaluation pieces, just asking the applicants to submit some upfront information, establishing a few baselines as it relates to the intended outcomes. And then finally, we ask the applicants to submit a sustainability plan. Again, one of the components of the CMS RHT funding initiative is that these initiatives are sustainable, and that can be in a number of ways, either by creating, insurance reimbursable medical services, or creating opportunities for individuals to be on staff, so that you are creating environments in which reimbursable medical services may occur, or however you plan to make the plan sustainable. Just a few notes administratively regarding the project narrative. The project narrative does have a maximum of 20-page limit, double-spaced, Times New Roman, 12-point font, 1-inch margins. Again, use headings and subheadings and respond to each component individually. The work plan, as mentioned earlier, requires at least 3 SMART goals and 2 objectives per goal. And again, the letters of commitment or agreement are required depending upon the eligible category, the category of the eligible applicant. So it's really important that you track your application again and your eligibility against the eligible application designations in the RFA. Next slide, please. So required components. So project narrative needs assessment. We're just asking applicants to provide a clear and concise overview of the rural health needs of the proposed program and how it will address the applicant will address targeted communities or counties, including frontier or tribal areas as applicable, with explicit alignment with one or more of the RHOAP key priority areas: chronic disease, primary care, behavioral health, and maternal and infant health. Applicants should discuss how the need was identified using local and regional data. You should describe the current barriers that prevent timely access, quality improvement, care coordination, or sustainable service delivery in those targeted communities. They should identify the RHOAP program category or categories under which the funding is being requested and demonstrate the applicant's eligibility. And if the applicant is applying as an organized partnership, consortium, vendor partnered model, or payer partnered model, describe the governance or contractual structure and affected rural communities. Next slide, please. So for the project work plan and impact analysis, so these are two components that are in alignment with each other. So the work plan components are a narrative and a template for this section that include the following: a detailed program description, describe partnerships that will be used to implement the project, including required letters of commitment, memorandums of understanding, or letters of agreement or contract. Attest to 5-year service commitment for incentivized employed providers where required. So again, we'll talk about that a little bit more in a moment. For projects involving VBP readiness and financial incentives, describe the pathway, payer partners, and how the model supports improved rural outcomes. You're to provide an organizational chart of those overseeing the program, a list of partnerships that will be used in the program, and using attachment E, include at least 3 goals with 2 objectives each in the work plan template. For the impact analysis, this is really just an estimate of the estimated impact of the program and a justification for how each estimate was determined in a format determined by NVHA. We would expect this to be done in a table-based format with the following information: number of patients expected to be reached by new or expanded services, number and type of new healthcare and non-traditional professionals expected to support implementation, the number and type of enhanced capabilities expected to be implemented, and any additional category-specific outputs and outcomes that demonstrate progress toward the RHOAP priorities. We would expect this impact to be used as a baseline for data reporting and updated on a quarterly basis, just to make sure that the funding that's being provided is having the intended impact, or if it's not having the intended impact, so that the state can work with each sub-awardee as they move forward. Next slide, please. So as I mentioned, one of the big components of the federal funding opportunity is that any funds used to support the hiring of new or current employees of a provider organization. So if it's staff that receive an incentive payment for staying, new staff that are hired as a direct result of the funding opportunity, HR 1 requires these recipients of RHG funds to accept a 5-year rural service commitment as a condition of award. This requirement was established under the HR 1 provisions and was carried over into the CMS Notice of Funding Opportunity. Further guidance from CMS describes how the commitment is operationalized. So what roles and settings qualify when the service clock starts, what documentation attestation is required, and the consequences of failing to complete the required term. The link at the bottom of the page here links to the CMS website where they've published a fact sheet, but more information can be had by reaching out to the Nevada Rural Health Transformation Office. It is the responsibility, however, of the sub-awardee to track, report, and enforce adherence to that 5-year service commitment requirement. That's something that CMS has made very clear, and I think NVHA would be willing to work with any subrecipient and sub-awardee on that component. Next slide, please. So just a few more bits of information. I won't read all of these off to you all, but these all come from the CMS fact sheet. Just noting, I think the big overarching principle here is that an individual that receives something of value specific to that individual, such as tuition support, housing assistance, relocation incentives, stipends, or recruitment and retention bonuses, are subject to the retention, the 5-year service commitment requirement. It does apply. It also applies when the support leads to financial support that's provided leads to credentialing, a degree, licensure, or a direct rural clinical job opportunity. And so it doesn't apply when there's more like broad workforce infrastructure. Like, for example, if you're setting up a pipeline that identified individuals that might want to go work in rural healthcare. And so the infrastructure associated with that is more global and not specific to an individual. And that's really the big, the general way of looking at this funding requirement. So the commitment is satisfied, if Um, it's when a service is performed physically in a rural area within the same state. Um, Providing telehealth from an urban location does not satisfy this requirement. Um, Time associated, like when a person is engaged and serving their 5-year service commitment, the time that they serve can be combined across multiple rural sites within the state, including time spent during rural residency or training years, plus later rural practice years. And so the consequence of this is CMS may end up recouping funds from NVHA if the service commitments are not complete. And so it's just something as being good partners here with the subawardees and the state agency, it's a good idea to just make sure that you all are working in close conjunction with NVHA as you carry out these requirements. Next slide, please. Project narrative data collection and evaluation. So required in the narrative is providing performance evaluation measures that correspond to the goals of your program. Again, the state has listed out a few different components that they'd like to see from the applicants, but largely many of these will be of the applicant's design. Measures indicated in the impact analysis should be a part of the overall program evaluation. So the application is asking applicants to determine what data will be collected to measure the success of the program, data that will be used to indicate if the program is successful and how the applicant will know it will be successful, and will the program improve health outcomes for rural Nevadans. And I think a big component of this is just as part of your acceptance of the award, you will be working with the state on quarterly data reporting, and these data elements will be included in that quarterly data reporting as you go forward. Next slide, please. And then finally, and then as part of this is also the sustainability plan. The applicant should describe their strategy to sustain program improvements beyond grant funding, identify post-award funding paths such as reimbursement, grants, donations, or a fee scale, and then describe long-term operations, staffing, partnerships, and ownership of continuation. So how would you propose to continue the supporting the initiative, and what are the long-term goals and plans for meeting that challenge? Next slide, please. And finally, letters of commitment. Once again, just pointing out, it directly corresponds to your eligibility category, but in all other instances, these are optional. So letters of commitment can be provided from organized partnerships, including a combination of managed care plans, providers, or local or state agencies. Must be supported by strong letters of commitment or MOUs from local or tribal health officials, rural hospitals, or other healthcare providers of services located in the community impacted by the proposal, along with contact information of all signatories in the letters of commitment or MOU. Intent to contract, letters of agreement or contract. This could include technology companies, vendors, and financial incentive arrangements between payer and providers, which require supporting documentation in the form of an intent to contract, a letter of agreement or contract. These supporting documents must provide sufficient information of the intent to formalize or already formalized contractual relationship between parties to ensure commitment, measurement, financial arrangement, and patient data protection. Letters of commitment, intent to contract, LOA, or contracts do not count toward the 20-page limit of the project narrative. That's really important to make sure that we give plenty of opportunity for the applicant to describe the program they're proposing to implement, but then also to not penalize those providers or organizations that have to submit a letter of intent so that their application can be robust and complete. And then the letters of commitment can also be robust and complete as well. Next slide. Scoring criteria. Next slide, please. There we go. So just to give a primer on how these pieces of information will be scored, if you've been a part of any of these workshops already on any of the other RFAs, we try to keep to generally a 100-point scale for the applications. In this instance, the budget narrative is 15 points. The budget plan is 15 points. The entirety of the project narrative is 70 points. And then the letters of commitment will be a pass-fail. So again, going back to the required element or not or optional letters of commitment, we wanted to make sure that we weren't assigning any points to that, but that if it was a required element, that it's included and these documents are complete. The evaluation committee for these proposals will largely score these on a scale of essentially outstanding, which means fully developed, well supported, and above the baseline requirements. Very good, which is detailed, supported, and comprehensive with only minor weaknesses. Satisfactory to good, which is most elements are addressed, but detailed or support is still limited. Or poor, which includes major gaps and deficiencies that undermine implementation. Next slide, please. Post-award requirements. All right. So just to point out for any applicant that's fortunate enough to receive a subaward, there are going to be regular cadence of reporting under these grant awards. So there will be a requirement for monthly fiscal reports and quarterly progress reports, which will be required until the funds are fully expended. Annual fiscal and annual progress reports are required for the reporting period, and then final evaluation is due within 30 days after the spending period concludes. These align closely with what CMS is asking of NVHA, and some of the data elements that the applicants or the subawardees will be providing will be incorporated into NVHA's reporting to CMS. So the completeness of that reporting is very, very important to the success and future funding that NVHA would like to receive from CMS on this front. As I think with any other opportunity, we would expect applicants to be prepared to provide supporting documentation and other data as requested by NVHA. Subrecipients must propose process and outcomes measures using calendar year 2025 as a baseline, specific to their strategy that aligns with the state's outcome measures for the RHOAP initiatives. So for the 2025 baseline and progress, generally speaking, the state would like to have applicants report to the extent possible the number of new healthcare providers and non-traditional professionals employed by the organization to support new or expanded services, the number of patients seen by the organization, the number of patients referred and or seen by the new expanded services and or integrated care model, and the number and type of enhanced capabilities the provider or partnership added or expanded of services, including integrated care models. Again, this is largely to encompass all the different possibilities that may occur under the RHOAP funding initiative, and applicants should report the ones that are specific to them to the best of their ability and work directly with NVHA to make sure that that data is complete. Next slide, please. All right, more. So round one of applications are due June 26th. It's not a lot of time, but we understand there's a bit of a time crunch here. The RHOAP funding is available, will be $26.99 million available for this first budget period, and the state anticipates final decisions being made by July 27th. And I think, Jason, I wasn't sure if you were going to jump in here or if you'd like me to keep going. I'm happy to do that.
If you want to keep going, you're doing a great job.
Thank you. It's always nice to hear. For the submission process, as noted on that very first, as we started talking about these administrative steps, don't hesitate to start your vendor application with the state. But applications must be submitted electronically using pre-populated links in each RFA. There's some nifty links in there that will populate an email for you, and you drop your application in the email. Question and answers are posted weekly, but any questions you have arising from this conversation should go to NVHA's static mailbox, which is checked on a regular basis, and responses, I believe, are published weekly as questions come in. And then the subject line, as specific to your application for this particular instance, please make sure to include the subject, the RHOAP funding opportunity using RHT RHOAP RFA in the subject line of that email. And then again, applicants should begin the vendor registration process as early as possible. So this RFA was released on May 7th. The first round one funding is applications are due June 26th. The state anticipates final funding decisions by July 27th. The project spending period. So this is this is specific to this particular funding opportunity from CMS. The state is what we're calling obligating this funding through these RFA awards. Those applicants have until August 30th, 2027 to spend the money that is received. according to the state's timeline. The state then has until September 30th to close out the first budget year of funding for CMS before this, as the second year of funding begins. There's some overlap between year 1 and 2, but it's very important that all these dates are adhered to so that the state can benefit from all the federal funding that they've been awarded and that there's no penalty to the state on that front. Next slide, please. And again, I just want to say thank you all for your time and attention today. Again, just to reiterate, choose the opportunity in this RFA that best matches your primary strategy. Anchor every request in documented rural health shortage data and a credible work plan and sustainable implementation approach. And make your budget traceable, the partnerships real, and the service commitment terms explicit. That way you're ensuring you're giving the state the clearest possible opportunity to evaluate your proposal and make good funding decisions under these opportunities. If you have any questions, please send your questions to the RHTP mailbox. Jason and team are doing a great job of monitoring it on a regular basis and are working hard to answer all questions that come in. So please send any questions you have through there. And with that, I think we have one more slide and I will turn it back over to Jason.
Okay. Thank you, Marie and Andrew, for your guidance through this wealth of information. There's a lot there. Just as a reminder to everyone, this slide presentation, as well as the recording, will be posted online at our RHTP webpage for your future reference. We encourage you to explore the webpage for not only information regarding this initiative, but any other initiative that we have provided for our program. So thank you again, Marie and Andrew. You guys do a marvelous job. We are so blessed to have Milliman as a partner in this project. They have been so instrumental and critical to our successes. Right now, I think we can open up to some questions. I think some questions can be handled through the chat, but we'd also encourage anyone to raise their hand and come off of mute and ask some questions. I'd also encourage, just so that we have enough people to answer all the questions and we can answer them properly, if any of members of the RHT team is online and may have a great answer for any of the questions, please feel free to jump in. We'd love any help to make sure everything is done appropriately. So I'll open to questions at this time. Alexa, we have you raising your hand. If you want to come off mute and ask your question, that'd be great.
Hi, can you hear me?
Yes.
Perfect. Okay, thank you so much for having this workshop. It's really, really helpful. So I have one question about provider reimbursement. So I have several projects where clinicians and providers are on the project as contributors to the project, not necessarily part of the mechanism of implementation. So they're part of like the planning and the strategy and things of that nature. They're not necessarily actually providing the care itself. And I was wondering how exactly you would like us to kind of reimburse them for their time, because obviously it's not even a question for any of the other team members. But I was wondering how exactly the state would like for us to deal with that particular situation.
That's a great question.
Can I ask a follow-up question, Alexa?
Absolutely.
Are those providers, when you say they're providing services, are they providing services that are currently reimbursable by a current payer? in the healthcare space, or they like, do you
No,
mean
so
like
I'm
under the program?
I'm imagining less like they're seeing patients, right? That would obviously be reimbursed through like Medicaid or Medicare.
Mhm.
This is they are part of the team